Good evening, everyone. Today I am presenting a journal regarding risk factor and microbiological characteristic of keratitis-related endophthalmitis. So first we should know what is keratitis-related endophthalmitis. It is the endophthalmitis which develop after primary keratitis, which is the type of exogenous endophthalmitis with very low incidence of approximately 1 to 1.5%, which means out of every 100 cases of keratitis, only 1 to 2 patients develop into the endophthalmitis, which leads us to the question of that which are the cases that we should be more vigilant and should follow up more frequently so that we do not miss the vision threatening condition. So, we have tried to find the answers of these questions by studying this literature. This is the retrospective study conducted at Shandong First Medical University, China during the period of January 2018 to December 2020, 3 years. Data was collected from electronic medical records. Which are the inclusion criteria? So, microbiologically proven cases of bacterial keratitis with hypopyon and bacterial endophthalmitis were taken into this study. Along with clinical characteristics, diagnosis of bacterial keratitis was confirmed with corneal smear and culture reports. And for diagnosis of endophthalmitis, along with serial USG-B scan, vitreous tape or AC tape was done. Keratitis and endophthalmitis with fungal etiology and follow-up of less than 30 days were excluded from this study. So during these 3 years of study, total 1,887 eyes with bacterial keratitis and 283 eyes with endophthalmitis were treated at that hospital, out of which 537 eyes with keratitis and endophthalmitis meeting the inclusion criteria were included in this study. So authors have divided them into 3 groups: BKH group, BE group, and BKE group. For simplification of this terminology, we should remember this terminology as this will be carried forward in subsequent slides of this journal. So what is the BKH group? It is keratitis with hypopyon group. BE group means bacterial endophthalmitis, which is not developing after keratitis. So which are the endophthalmitis included in this? They are postoperative infective endophthalmitis, post-traumatic endophthalmitis, bleb-associated infection, and endogenous endophthalmitis. And BKE group is bacterial keratitis-related endophthalmitis, which means endophthalmitis was developed after keratitis. So BKH, BE, and BKE, these 3 terminology we should remember. So which are the parameters that were assessed during this study? So patient demographic data, predisposing risk factor for developing endophthalmitis from keratitis, clinical profile of these patients, microbiological profile, and antibiotic susceptibility of these microbiological organisms were analyzed. So what is the demographic data we found in this study? That in every group, they have male preponderance with BKH means bacterial keratitis group was tend to be more elder than BE means bacterial endophthalmitis group. What are the risk factors they found? For calculating risk factors, p-value of less than 0.05 and odds ratio has been calculated. So first is presence of hypopyon. Percentage of patient having keratitis without hypopyon developing into endophthalmitis is approximately 1.48%, while the rate increases up to 10% in patient having keratitis with hypopyon. So hypopyon is a risk factor. Height of hypopyon. As we can see in this data, BKE means endophthalmitis developing after keratitis has height of hypopyon of approximately 2.67 mm, which is higher than rest of 2 groups. For this, authors have calculated odds ratio for height of hypopyon less than 2 mm, 2 to 3 mm, and greater than 3 mm. First of all, we should be knowing what is the odds ratio. Odds ratio is strength of association of event occurring in exposed versus non-exposed group. It suggests that this is not a random association and it is a so odds ratio of 1 means the chances of event occurring in exposed and non-exposed group is similar, and ratio of greater than 1 suggests that event occurring in exposed group is higher. So as we can see in this, height of 2 to 3 mm and greater than 3 mm has a ratio of greater than 1. 2.09 in 2 to 3 mm and 4.12 in greater than 3 mm group. Corneal perforation was found In keratitis group 17.16% and endophthalmitis following keratitis was 39.29% with p-value of 0.01. Open globe trauma with intraocular foreign body was also a risk factor. Other risk factors that were assessed are contact lens wear, presence of pseudophakia, presence of aphakia, PCR, and iris coloboma. So, we concluded risk factors. After that, what is the microbiological characteristic in each group? So, in patient of group of bacterial keratitis and bacterial endophthalmitis not related to keratitis were Staphylococcus epidermis, Streptococci, Pseudomonas aeruginosa, followed by Staphylococcus aureus. While in bacterial keratitis related endophthalmitis, Pseudomonas aeruginosa followed by Staphylococcus aureus is seen most commonly. So as we can see that in keratitis with hypopion group, Staphylococcus epidermidis and Streptococci were the commonly found organism, while they are not transforming into the endophthalmitis. But Pseudomonas aeruginosa and Staphylococcus aureus has higher transformation rate. So, after knowing these two organisms which are most commonly associated with BKE group, which is keratitis related endophthalmitis group, we will now see what is the antibiotic susceptibility for these two organisms. So, for Staphylococcus aureus, we will see what is the antibiotic susceptibility across the three groups. So, as we can see here, that vancomycin is similar in all the three groups, while other rest of the antibiotics BKE group, which is endophthalmitis following keratitis group, has less antibiotic susceptibility for Staphylococcus aureus. So these leads and methicillin resistant Staphylococcus aureus infection is also higher in cases of in group of BKE. 40% was found. So this leads to question that why the similar organism which has caused keratitis and endophthalmitis antibiotic susceptibility are different. So, probable reason for this could be difference in the microenvironment of the infection site. One is cornea, while other is vitreous cavity. Bacterial phenotypic adaptation, difference in antibiotic penetration and drug availability, and biofilm formation. So, now we will see the antibiotic susceptibility for Pseudomonas aeruginosa. So, we will see for ceftazidime, aminoglycoside, and fluoroquinolone. As we can see, this antibiotic susceptibility are almost similar in all the three groups, that is keratitis related endophthalmitis and bacterial endophthalmitis group. So this leads to question that why Staphylococcus aureus was having different antibiotic susceptibility and Pseudomonas is having similar susceptibility. So probable reason for this could be, unlike other bacteria that changes the behavior in response to the immune environment, Pseudomonas is already highly resistant in every environment. Biofilm formation is not limited to specific eye structures and high adaptability but consistent resistant profile, which means Pseudomonas is already resistant whether it be cornea or vitreous cavity. So these lead to important information that we should not depend on corneal scraping for antibiotic susceptibility, and vitreous tape or AC tape should be done in every case of keratitis related endophthalmitis because the sensitivity and susceptibility for organism is not similar in keratitis and endophthalmitis. So which are the limitations of this study? This is the short duration study, retrospective in nature, sample size is less, immune status of patient is not specified, only bacterial etiology is taken, although fungus is the important causative organism for such cases. Visual outcomes were not assessed in this study. So we will now compare this study with previously done two major studies. One is done by Henry C.R. et al., which is 15-year study done at Bascom Palmer Institute from 1995 to 2009. Total 9,900 cases of infected keratitis were included in this study, out of which only 49 eyes progressed to endophthalmitis. This led to incidence of 0.5%. In this study, patients were divided into two groups, primary keratitis developing into endophthalmitis and surgical wound-associated keratitis. Endophthalmitis for after intraocular surgeries, bleb-associated endophthalmitis were excluded from this study. So in that study, risk factor found were topical steroid use, history of previous surgery, corneal perforation, dry eye, relative immune compromise, organic matter trauma, and contact lens wear. Gram-positive bacteria followed by gram-negative bacteria and fungi were found to be the causative agent in that study. Final visual acuity were poor Enucleation or evisceration was performed in 31% of patients. So they have assessed visual acuity and management protocol also in that study. Antibiotic susceptibility, gram positive were susceptible to vancomycin, followed by fluoroquinolone, and gram negative were susceptible to ceftazidime, aminoglycoside, and fluoroquinolones, which was similar to that found in our study. Other study of 14-year study, which they have studied 38 eyes, and that associated systemic condition like diabetes, HIV, and immunosuppressive therapy was present in 60% of patients, and 60% had history of previous intraocular surgery. So these are the risk factors they found in that study. Out of 38 eyes, 90 eyes received intravitreal injection followed by PPV in 5 cases, and in 8 cases, and 5 cases underwent corneal transplantation. 19 eye with no light perception underwent enucleation, and final visual acuity was poor. So risk factor they found is so after this 2 study, if we cumulate this risk factor, immunocompromised state like diabetes, HIV, cancer, steroid use, history of trauma with intraocular foreign body, pre-existing decompensated corneal condition, contact lens use, keratitis with virulent organism, drug-resistant organism, sulcus placed IOL, ACIOL, aphakia. These are the risk factors that they found in previous 2 studies. So, what is the purpose of this study when already this 2 major study has been done and they have found these risk factors? But if we look at this risk factor, they are very much generalized and do not specifically point at any clear picture, because these are the risk factor for developing keratitis also. And if we consider this risk factor, then incidence of bacterial keratitis related endophthalmitis should be greater than 1 to 1.5%, which is not the case. So in this study, they have assessed the parameters pertaining to characteristic of keratitis itself, which was not done in previous 2 studies. So whenever we encounter any patient with keratitis, what should be the criteria that we should look that this patient can undergo into endophthalmitis? Following this study is corneal perforation, increase in the size of hypopyon size of greater than 2 mm, infection with Staphylococcus aureus and Pseudomonas aeruginosa, along with the risk factor which are enlisted in other studies. So take-home message from this journal is that we should be focusing on these 4 risk factors. Along with that, vitreous step in every case of keratitis related endophthalmitis should be done, and antibiotic susceptibility only based on corneal scraping should not be validated. Thank you.
Yeah, nice journal. So you have already listed the take-home messages that there are not all the patients with bacterial keratitis. One, you should realize that the incidence is very less. So with no hypopyon, it is in single digit. No, it's less than 1%, 1 or 2%. And if it is with hypopyon, the incidence is again less than 10%, about 9 to 10%, I would say. So overall, this is not something which is very common. Again, this arises a question that do you need serial ultrasound in all patients? Is something which becomes, because you are talking about an entity which has got a very less incidence. Whether, and we know that many times the view is not there. It's only on the ultrasound B scan you make a call whether the echoes are there, and you little bit tilt the probe, the echoes will go in the posterior cavity. So just looking at, so what other features you should look for? Like when you will do that, you will think clinically that this patient is now progressing from a keratitis to endophthalmitis.
Sir, if there is a view, then we should look into the glow of the fundus. Correct. If the change in the glow is there, then we should suspect.
If view is there, you can look into even exudates. There will be many things inside, but view is hazy. Yes, glow is there. Some idea you can get. Anything else? Anybody else? Ayushi?
Patient, the pain will increase. Photophobia will increase.
Yeah, pain, photophobia. Anyway, with keratitis, they will have.
If
sometimes
there is a sudden increase.
There is a sudden change. Yes, even floaters patient will tell. You may not feel the floaters. Like you may not see the thing, but some light is going in. So increase in floaters is something which patient can still tell even though the vision may be low. correct? Then,
Further drop in vision.
yeah, again, we don't measure vision in these cases. Any other features? An ultrasound, what you will be looking at?
Echoes posteriorly that are present into the
Huh?
anterior vitrecous may be corresponding to the keratitis itself. If we see echoes in the posterior vitreous cavity membranes and more of clump.
Choroidal thickening, you can look into
Choroidal.
multiple features which you see in endophthalmitis. Even early in the course of disease, these changes can occur.
A lot of time there may be some inflammatory spillover. So how to differentiate that from whether it's inflammatory or infective?
Usually, anybody you want to take this? How will you differentiate whether it is inflammatory spillover or it is real endophthalmitis?
Based on the location of echoes.
Yeah, location, one they say, but more than location. So, if there are uniform small dot-like echoes in the anterior cavity, in endophthalmitis they tend to gravitate down. So you'll see more of the echoes in the inferior thing, and you'll have more generalized. It's not interior, but as I told you, sometimes anterior, posterior. If the same person, the same type of scan he is taking, he can still know. But because we have every time a different person taking a thing and his protocol is different, the image he has captured would be different. So you need to look for other features too.
So in follow-up also, sir, sometimes because of the ulcer, they don't want to start topical steroids. So in the follow-up scan, suppose the echoes increase, how do we attribute whether is it because of increase in inflammation or it's progressing to endophthalmitis?
It will never go to posterior cavity. You will not have other features. If other features are there, do a vitreous stab or go in. Like you need to definitely think towards endophthalmitis rather than thinking that it is just increase and increasing steroid. Only steroid you will not give anyway.
As long as descent is intact, very, very rarely it will be endophthalmitis. Let it put is very simple. Okay, very, very. See, once it's perforated, then there is no issue. Then obviously, then you have to take it for granted that you are having infection is gone inside. But as long as descent is intact, very rarely it will go. Like that's why we always have even or post-graduation we always used to taught hypopyon corneal ulcer versus corneal ulcer separate. Though you have hypopyon, but that's mostly is inflammatory, not infective. Okay, and echoes, yes, these are gross changes. What Rajiv says, these are more or less it fits. But you looking at only ultrasound echoes, you never can say this is hemorrhage or this normal other echoes or whether you are dealing with the infection or just inflammation. It's more or less experienced person, more or less you have subtle guess, but nobody can confirm that what you are really doing is endophthalmitis or it just are pure the normal echoes or because of anything else. Okay. So, but yes, perforation, then this you are in definitely.
How often do you get hypopyon in a corneal ulcer?
Please also, sir, I don't know exact incidence of
No, it is purely due to the virulence of the organism.
It's a
Very
violence of the organism.
It's a virulence of the organism. If you see hypopyon in a corneal ulcer, as Sir says, so there's definitely some breach in the desmids or in the endothelium. Otherwise, you won't have an inflammatory reaction. Hypopyon is only an inflammatory reaction. Doesn't mean that
You can still get it.
No. You can still get. It's a severity type inflammation. It's not uncommon. Let me put it.
Sir, what I'm trying to come to is a different thing.
Yeah.
I'm not saying that. It is again contextual. I'm not saying that you don't get hypopyon. You can get hypopyon. Again, it depends on the virulence of the organism. You can't have a small, tiny ulcer and zero. If you have a disproportionate amount of inflammatory reaction in the antechamber, definitely it is a virulent organism. But that's what I'm trying to say. So it's the virulence of the organism depends. It doesn't depend whether it is the size of the ulcer. It is the depth of the ulcer which is more important than whatever. You can have organisms without you may have absolutely clear, you may have a descematous clear edges, but there will be infection inside because some organisms go right across the, for example, pneumococcus, streptococcus pneumoniae, You can get ulcer, they're classic hyperpion ulcers, where you get, but even that ulcer, so you know that this is a virulent organism which is causing the hyperpion. Your what you call study has shown that a large amount of hyperpion. So again, ultimately comes down boils down to the fact it's a hyperpion ulcer, is meaning it is showing that there is neither responding to your medicine, the treatment that you're giving, or the virulence is so high that your dose or your medication is not effective enough.
Yes.
So, which is risk factor for the next stage of ulcer, that is perforation. And when it perforates, then you cannot say anything about endophthalmitis. You have to assume that it is going to go behind.
Yes.
And so, whatever echoes that you see, whether you see in the ultrasound or not, you have to assume that this is definitely breached. It is gone, definitely, because now your lens has come forward, your zonules are stretched, and everything is now. Where will the hyperpion collect then? It has to go somewhere. It'll go. It'll breach the anterior xyloids. So you have to assume that it is definitely an infection behind. But don't go by what is there in the vitreous cavity on the ultrasound. You have to take a call, because if a perforated ulcer, flat AC, anyway they're going to go inside and they might want to do a therapeutic PK. That's the best time to go and take a sample also from the vitreous cavity and give an intravitreal injection.
Yes, sir.
So by not doing, you're wasting time. But better is, suppose if they're doing any treatment for that, if they're going to the theatre and do it, that time please go, give a prophylactic antibiotic inside the eye. Even if you say the vitreous cavity is clear, and this is the best time to go inside and give it.
Yes, sir.
And take a sample if at all.
Probably sometime what happen if you're not infection spread, if there's a breach, if a separate pars plana you're going and this leave it standalone, probably that's a different ball game.
Because no, separate only. It's
separate
never at
only.
the same time.
Yeah.
Never in the same position.
Yeah.
Always entry is pars plana.
Rather, I would prefer if they are doing a therapeutic PK, if there's something they are planning, that is the time, maybe open sky, have a look at fundus, and if vitreous cavity clear, don't touch, because we are not, there is still undisturbed, particularly phakic eye, better leave it that way. But if you see exudates, then definitely that's a different ballgame. Yeah, yeah.
I will disagree on that. If there is a phakic eye, I will not touch. But if it is pseudophakic, aphakic, or it is something, I will definitely.
Aphakic is no issue. Aphakic is, there is no issue at all.
Also I'll give, sir, because they might not sometimes remove, because they sometimes don't remove it.
Yeah.
They keep the lens inside and they put the PK. But if it is pseudophakic also, sir, I'll go and give the injection inside the eye. Only phakic eyes I might not. And sir, it is very difficult sometimes, sir. It's a total corneal ulcer. They put a full graft. You can't see fundus only.
No, that's exactly the reason before putting draft. Better, that's the opportunity. Request them to call one of us if they don't want to see. Won't mind going, and that's the best opportunity. And rather the other, that is the only opportunity you will get to see. So that's why. So sometimes you won't mind going and having a look at it.
Correct.
But what you had mentioned about taking an AC tab, that is sometimes actually a good idea. If you have so much hyperpion, better to take an AC tab. Also along with the bacterial this thing. See, AC tab, which is going to the cornea instead of going in the
thing which I learned from this, many times corneal scraping shows organism, and we are sure that that's the organism inside. It's fine. Organism will be same. But to look for antibiotic susceptibility, do a vitreous tab, because that finding and the scraping finding will be different. So that is something which was a good learning from this.
Yes, sir.
Lot of times, even in perforation, they do a glue BCL, not go for a PK. So in such a situation, giving an intravitreal also is difficult, because the glue can discharge with high
those
pressure.
cases, obviously, you have to take a call.
Problem happens the moment it comes to end of sight, it goes to retina, everything.
Yeah.
So cornea. So I think if we can manage a corneal bacterial keratitis from the cornea side, and if it is not causing end-off and we assume and go in, that's again wrong, because a lot of complications.
You don't want to make it a single cavity.
Yeah, so definitely you don't want to go. Another good thing which has come is looking at which are the cases you want to really do a very close serial ultrasound is perforated, the two organisms, and high hypopion. Rather than a small ulcer with a streak hypopion coming every second day. Either first, suppose you have seeded VRE, it will continue for next 1 week every second day. Sometimes there will be some echoes in the mid cavity, some anterior, and that becomes a problem. So I think if these risk factors are there, understood that we should do a very close watch.
And disproportionate reaction. This is what you see in ulcer, but you see so much hyperpion. or you see, say, patient is complaining of pain, so much symptomatology is there. You know that this is not only one single tissue is involved, it has probably involved the ciliary processes, ciliary area, which we cannot see because it's in the blind spot of the eye. And ultrasound cannot be really done for that very anterior structures. Even if you do standoff, you might see some echoes, but you can't depend on that. So clinical judgment, I think it's only the organism. If you can get a good tissue sample, that's the best thing. Once you know that what tissue, what organism it is, you can actually take a very firm decision regarding whether we should do more aggressive treatment or take it depending on the medication.
Actually, when you start, if a disease start as a corneal ulcer, very, very unusual, and it is remain in the cornea, even
Yes,
though
sir.
hypopania is very, very unlikely you are having endophthalmitis. Extremely rare. And that's exactly the reason we don't want to breach cavity,
Yes.
don't want to go in, all those things. Yes, perforation is totally different ball game, what you're talking about. But yeah. Yeah.
It's not
Yeah,
easy to
so-
become endophthalmitis.
No, because
See,
no,
a lot
but
of
what you are
barrier,
talking,
natural barriers
Chetan,
are
is that is always a routine thing. Like lot of cornea crosses we get, and you have hypopia and ultrasound. They will do in some few because rule out endophthalmitis.
Yes,
No, you cannot rule out endophthalmitis totally. But at the same time, most of the time it is not endophthalmitis. But you cannot just say that it is not endophthalmitis 100%. But what Rajiv said, patient is responding. Let them handle corneal ulcer. And if settles down most of the time and as symptom relieves, you will realize you are, that's it.
I think the 4 criteria which the study found are pretty good: Pseudomonas, staph, perforation, and height of hypopia on more than 2 are somewhere. These are the 4 you should have a regular serial ultrasound, but rest of them, only if clinically they are worsening, they should be sent rather than on a routine basis.
Yeah, but this is only for bacterial keratitis. No, please don't confuse this with fungal keratitis.
Correct.
That is different. It's a complete different ball game. It doesn't come with symptomatology the way bacterial keratitis comes. It's more
this is only for
very indolent, chronic, and there those echos are more dangerous than what you see in bacterial. You can't even give steroids if you have a fungus. There you need to do debulking is the way to go about it, because medicines may not have an immediate effect. It takes a very long time. More aggressive.
Yeah.
If so, fungus. This
is also
this
included in
this
that
thing
list.
is but in that list fungus is there.
No, they
But
don't know, but we can
journal is
include
only
them.
bacterial, isn't it?
Only
Study.
Journal is only
bacterial.
bacterial, but fungus is totally different.
But that can be, but the serial ultrasound
Yeah.
can be included.
So ultrasound, I think what she said is more important. The vitreous membranes and the posterior vitreous echoes. Those are some clues that these things have gone a little posterior.
Sir, in other studies which were done previously, the fungus was shown to be the most common causative organism for causing endophthalmitis, and the similar authors have done other studies for fungal keratitis with hypopyon. They also show that a mixed organism and fungus is higher risk of developing into endophthalmitis.
Yeah, and one more thing is we must imagine that some of the studies are done in Western world. They may not have the same microbiology profile like us.
Yes.
So we will definitely have more mixed infection. We may have more fungal infections, not bacterial. It's more likely that we'll have mixed or fungal
sir.
infections. So whenever we see, we are always worried about the fungus part. Bacterial, yes, we can manage with all the antibiotics, but fungus is so difficult. We have only a few medicines for us to use on them. And that also susceptibility is very different.
Yes, sir.
Some of them are resistant.
Just one question. So they had these 3 groups.
Yes, sir.
What was the purpose of having only bacterial endophthalmitis group with other etiologies
Sir,
in this study?
it was found that endophthalmitis developing from primary keratitis. This study mainly focused on that part. In bacterial endophthalmitis, they also included the wound associated keratitis developing into endophthalmitis, other endogenous endophthalmitis, and bleb related endophthalmitis.
No, that's what I'm telling. What was the purpose of having that group? So you had one group, bacterial keratitis, hypopyon, anything following which they developed endophthalmitis, which was 28 in number. And you had another group where they had bacterial endophthalmitis excluding these 28,
Yes.
but any other type of endophthalmitis, which was about 200 of them.
Yes, sir.
what was the purpose of having these two groups? Did they do any comparison between these two groups?
Comparison, no sir, they didn't.
They did only microbiological comparison. Your microbiological table and antibiotic susceptibility,
Yes, that
they did. But any other parameters they compared, because it would be interesting to see how these endophthalmitis behave as compared to the others.
No, sir. Mainly the demographic characteristic and microbiological and antibiotic susceptibility was only focused on Pseudomonas and Staphylococcus aureus. So they didn't compare these three groups.
What should be the duration of serial USGs?
Duration means intervals.
Intervals.
So depends. You can do it every other day, second. But don't subject the patient for everyday ultrasound if there is no change in the clinical parameter.
Yeah, it also, once there is a keratitis, they will start the therapy. And if they are not responding or poorly responding, definitely you want to do it. But if it has started responding, hypopyon has reduced, everything is improving, definitely they don't need.
There's no set protocol. I mean, you have to follow the patient, look at the clinical course. You can't just say every second day I should ultrasound. And if you don't do, it's wrong. I'll punish you. That's not the truth.
Following up, try to see the fundus. Sometimes you might feel it is hazy, but if you put the IDO and try to see, you can sometimes see through that haze. So the details can be seen. So follow up, always see the patient before you do the ultrasound.
If I'm able to, I look for the disc. If I'm able to see the disc now, I'm quite sure that there's not so much vitritis. Even if it was there, I would say disc is there, that means it's okay. There's not formed vitreous. It's still not really bad. But if the infection is not gone back, you will not be able to see anything because it has to go from the anterior to posterior, so it is going to invade the antivitreous. Then you will have zero view of that. So what he says, good red glow, she said, it's a good sign. Things are okay. If you can just see the disc through all that haze, still a good sign. You're happy that at least I can see the disc. So you have to spend some time trying to look at that. Just don't look at a steamy cornea and say, no, nothing is everything. We'll just do ultrasound straight away. Try to look. Make the smallest pupil of indirect and try to look through all. There will be some area where the cornea is slightly clear. Through that, you try to look at the thing. Of course, if there is a pupillary membrane or a significant hypopyon, you might not be able to see, but try. Must give yourself at least 2-3 more minutes just to look for that glow which you can get.
Anybody wants to add any point online?
I'm JP here. I want to ask one question because I've always felt that if, like PB sir said, if the vit cavity is totally clear by giving one intravit, don't we run the risk of taking the commensals from the conjunctiva, which will also contain the bacterial and whatever corneal ulcer germs, and putting it into the vit cavity? Couldn't we just leave it untouched unless we definitely see a spillover into the vitreous cavity?
That's exactly what we discussed. You are right. That's exactly what we discussed now.
Okay, sir.
Now, as far as, unless you are having a doubt, definitely we do not want to disturb vitreous cavity. That's exactly what we discussed.
Okay, sir. Okay.
Yes. Not only on assumptions we do not want to, because most of the time it doesn't, as long as I said, desmus is intact, unlikely it is going into vitreous cavity.
Okay, sir.
Yeah. That's what Chetan was discussing. Look at a more like a follow with the clinical science and everything, and we'll take a call accordingly. Worsening of symptoms, real or ultrasounds if necessary. All those indirect parameters we'll look into it and then decide about it.
So, ma'am, we don't give prophylactic antibiotics in the vitreous cavity.
Yeah.
We don't do that. On the basis of ultrasound, definitely not.
Okay.
Sir, I have one question. Sir, there are many fungus which can cause intact cornea. So should we, if there is no corneal perforation, so how can we follow up these patients?
Fungus?
Fungus which can which can penetrate the intact cornea, and
Which one?
See, this all applies for bacterial. Fungal, definitely the chances are high. You are more vigilant about it, and these are the ones where you definitely want to try to do a serial ultrasound and clinical features deteriorating. There, the clinical features or symptoms may not be as compared to bacterial, but there you are on the side of doing early surgery probably.
But I'm not sure of any fungus in the intact cornea. There's usually some breach.
No, no, I think she's trying to say that the fungal corneal ulcer will have a hypopyon, no? And the hypopyon can be infective. So even though there is no corneal perforation,
Yeah,
I
ma'am,
think that is what they're trying to ask. So how will you follow up those fungal corneal ulcers with hypopyon?
when the problem is that we can't do give steroids also. So we have to depend on trying to control the fungal infection. So that is more important for us. Look at the corneal
I think
signs.
the same rule applies.
Yeah,
Still,
same
vitreous
rule.
cavity, you are very sure something. You don't give a prophylactic antifungal. There's nothing like profile, but you tend to look for more closely rather than, because in bacterial, as we said, that it's like symptoms changing, many things. Here you want to be a little. You see the response of that.
No,
Any
sir.
cornea person has logged in. They had a class actually.
So one more thing you must remember is that any antifungus that you give cannot be given for a day, 1 week. It's for a long time. And antifungals are systemic medications that can affect your liver. And medicines like voriconazole can even cause other side effects. Their metabolites can cause side effects. So you cannot give an antifungal prophylactically. You have to give it only if you prove that there is a disease and you have a high suspicion of disease, then yes, antifungals for a long time. It's not like bacteria. You give for a 1 week course, bacteria it's bactericidal. Most of the medicines are bactericidal. Fungi-static. Most of the antifungals are fungi-static. They become fungicidal only if they cross a particular dosage. But that doesn't happen very often. That means it's a really high dose you have to give. So when you give high doses, your risk of having systemic side effects are there. So you don't give prophylactic medicines ever. Oral, I'm talking about. Topical, yes, you can do. Topical, intravitreal, you can raise your dose of. We give amphotericin B in 2 doses.
Actually, quite common presentation will have a corneal abscess when you see about fungus. Scraping is the best way to get the organisms, and when you have a specific organism, particularly when you're talking about fungus, then you start. So you need some diagnosis there, and because is only cornea is involved, systemic antifungals probably again may not help because cornea is avascular. Unless water has come through aqueous and then blood aqueous barrier coming through a very unlikely adequate concentration. So the main treatment will be topical antifungals, and particularly those work superficially. Okay, I like natamycin and all those things. They have effect only on a very superficial. Again, endophthalmitis you cannot have natamycin because they don't have penetration. So you need to choose antifungal accordingly. Anybody is having any other doubt, any questions, or any additions?
No, I don't think why you are thinking limbal, meaning that it doesn't go by vasculature behind. It is the direct invasion. So I doubt that limbal involvement becomes important when you are thinking that there will be a systemic thing. It will go through the vessels and then go to vitreous cavity. The endophthalmitis following a keratitis is not through the vasculature but a direct invasion. So I don't think limbal involvement has a much role. It may have a role when you are planning a surgery, when you want to do a keratoprosthesis, or you want, because limbus involved means it's near to the sclera, there may be sclera. So those things you can think of, but for spread to the vitreous cavity, I don't think that has a role.
Limbal involvement may respond better to systemic medications.
You have learned about immune rings, no, in the cornea. So that is the immune defense system. So coming close to the limbus is actually good. It may heal it faster.